discussion that we can engage in to discuss this, what I think is a very, very timely and arguably one of the real silver linings of what has occurred with the unfortunate current COVID pandemic. If we could have the first slide, please, Ned. So the thought is to frame a discussion around telemedicine and digital health. Next slide, I've tried to provide some definitions. From my perspective, telemedicine is the remote, either synchronous or asynchronous communication of clinical information. I've tried to make that definition as broad as possible. You could certainly modify clinical to health, but the notion is, I think the key concepts are it's remote. It can either be synchronous or asynchronous. It is communication. It can be one way or it can be bilateral, and it's information. And the notion from my perspective of digital health is it's clinical or health information in a digital format. And again, you could expand on any of those components. I think the notion is it's moved from analog to bits and bytes. Next slide, please. This is a slide that I developed probably 20 years ago to explain what I have observed as the evolution in healthcare information technology. And I suspect that a similar slide could be developed for the impact of information technology on other industrial or sectors as well. From my perspective, they're really functions which are serial and dependent upon the preceding function. So if you look at the horizontal axis, it's necessary to capture data in a digital as opposed to an analog format in order to do transaction processing or act upon that data. Once you are engaged in transaction processing, it is possible to build a database. And then finally, once you have a database, it's possible to do decision support. Things like using technologies like natural language processing, like artificial intelligence. You can do predictive modeling, for example, but you can't do that unless you built a database, and you really haven't got a credible database unless you've been able to analyze some transactions that you've captured in a binary or digital format. And in healthcare, the focus has evolved initially from financial, largely because financial was much more quantifiable initially. The terms were, I think, better defined, and there was less ambiguity. So it was the thing that was logically moved to a digital format first. Then we moved into aspects like administrative, and in that I would characterize things such as appointment scheduling. And again, I think largely because there were better definitions, less ambiguity, and then we evolved ultimately into clinical. And in clinical, in my mind, incorporates a variety of things ranging from claims, healthcare claims data, to electronic medical record data, to now genomics, to digital imaging, and things like that. So the evolution of this activity of healthcare IT has gone from an analog to a decision support function, and it has encompassed both financial, administrative, and more recently clinical activities. Next slide, please. In terms of the technology, and again, I don't presume that this is an exhaustive list, but I just wanted to offer that I think it incorporates text, email, video, certainly connected devices, electronic medical and electronic health records, genomics, artificial intelligence, and natural language processing. So there are a variety of technologies that are utilized to accomplish both digital health as well as telemedicine. Next slide, please. And in terms of adoption, and this is within the United States, the data is a little dated now, but you would see similar, very rapid increases in the use of electronic health records on the slide that is to my left, probably, I don't know which side you're on. The one that is for physicians shows that it more than doubled in terms of market penetration from 2008 to 2017. And then you can see a similar slide going from really less than 20% to now almost 100% of hospitals. And this is largely a result of the very substantial federal subsidy of the adoption of electronic medical records by both physicians and hospitals that occurred, as you can see, in the 2009-2010 period. My estimate is that it probably was something on the order of $30 billion of investment. And if you would look internationally at other health or other countries, you'd see that the United Kingdom made a somewhat less, but probably on the order of magnitude of 10 to 15 billion dollars of investment to install electronic medical records. And so most of the developed world today has gone from a largely analog world to now a electronic medical record world. And they've accomplished that in the span of less than a decade. And I think that has now built a foundation for the ability to do things that were simply impractical in an analog world. Next slide, Ed. In terms of the market, there have been some enablers and there have been some barriers. From an enabler perspective, I think the commoditization and the broad distribution of technologies like broadband, of mobile technology, have made it possible, and cloud services would fall into this column, have made it possible to do things at a scale and at a cost that would simply have been infeasible, 20 years ago. So we've had, country and worldwide distribution and progress with these technologies. And then in terms of other things that have occurred with regulation, it has been possible to move across state boundaries and move from rural to urban areas, and utilize and manage issues around privacy and confidentiality. There's been enhanced reimbursement for telemedicine services, and I will share with you that even in the most recent months, we've seen a very substantial relaxation of the regulatory environment into which most providers functioned as recently as the first of the year as a result of response to the COVID pandemic. So we've got relaxed regulation, we've got enhanced reimbursement. Obviously, the presence of an electronic medical record made it possible for providers to exchange information with each other, with their patients, and that has been a great enabler. And then finally, connected devices. And in that regard, it really spans the gamut from what, again, a decade ago, things like Fitbit and an Apple Watch would have been, viewed as Dick Tracy-like technology, which are now consumer commodities and available, and they are enabling physiologic monitoring, heart rate monitoring, and pulse monitoring. The most interesting connected device that I've seen recently, because I think it may turn out to be a epidemiologic tour de force, is this digital thermometer, which I think is a great illustration of how in the past an analog device that was not connected to a larger infrastructure has been converted through the wonders of integrated circuits and technology miniaturization and Bluetooth technology into a tool that can be used in a pandemic to measure and monitor the presence of fever in populations. And so I think that is just one example of the kind of enablers that we are observing and how rapid the adoption has been. In terms of barriers, one of the key barriers has always been the requirement that, that providers be licensed in the state that they're rendering healthcare in. So if the patient is in Florida today, but I'm doing a telemedicine visit with a provider who's physically located in Massachusetts, historically that provider would have needed to have a license in Florida in order to render care to me. And that's been, I think, a substantial barrier to the more widespread adoption of telemedicine. And the FDA still regulates connected medical devices. I think they have tried in the last half a dozen years to be more accommodating. But at the same time, some of these devices are class 2, medical devices, and they require, certification, and that has a whole series of quality control implications that those of you familiar with medical device regulation know are non-trivial. And then finally, I think there has been a reluctance, to expand reimbursement. I think there have been two theories there. I suspect those theories have been rapidly dispelled in the last month, but they have to do with the, increasing demand for services because of the ease with which it could be done. And I think furthermore, the sort of lack of validation that telemedicine might be, cost effective versus the in-person visits. So those are, and again, I don't presume that these are exhaustive, but I think they're examples of enablers or barriers. Next slide, please. In terms of market characteristics, and those of you familiar with lectures that I've given in the past, I look at opportunities really with what I call the 5 M's. And in my mind, the most significant of which, and the gating factor of which, is the market. For reference, the other 4 M's are management, method, metrics, and money. And we could go through any of those, but I've tried to encompass some of those within the dimension of market characteristics. So the current estimates today, just to give you a sense, in the US, telemedicine is about a $2.6 billion a year business, but it is projected that it will grow over the next 3 to 5 years to something like 30 billion. So the growth rate obviously is very high. And I would say, just to give you some statistics that I've become aware of, it appears that less than 5% of medical care was delivered through a telemedicine type activity as recently as the first of the year. The numbers that I've seen actually suggest it might be around 2%. And just to give you some sense, there is some data that suggests as many as 50% of visits today during the COVID shelter-in-place phenomenon are being conducted by telemedicine. Now, obviously, that is of a skewed subset because there are a number of elective surgical procedures, which obviously, at least with today's technology, are not doable. Although I would point out that with the advent of robotic surgery, for example, there has already been exploration of whether you could do, quite literally, remote surgery. And I think that that is not an infeasible or unrealistic expectation that we would be technologically enabled to do that, I would say within the next 4 or 5 years. So, you know, one of the more famous venture capitalists that, you know, I know and rever, John Doerr at Kleiner Perkins, has often said that we overestimate the impact of technologic innovation in the short term, but we underestimate their impact in the long term. And that's because these technologies have an incubation period, but once you hit a critical mass, then obviously what you see is a fairly exponential growth rate. And I predict that with regard to telemedicine, we are going to observe that in 2020. I think we now have all of the components to make telemedicine, both it is certainly technologically viable, I think it is going to be economically viable, and most importantly, I think you're going to see fairly dramatic both provider and consumer acceptance of the technology and willingness to use it. And I think that just reflects in the same way that we can do this, hopefully, you know, technologically supported webinar today, you know, and most of us are learning how to use Zoom and BlueJeans and technologies that, you know, a year ago we might not have been quite as facile with. I think you're going to find that true for telemedicine. In terms of opportunity, this is a market that is really minimally penetrated. And in terms of dominance of any particular provider, it's a very fragmented market. So, you know, in terms of both investment opportunity and the characteristics of the market, these are the really early innings in the context of a fellow who has documented the technology adoption curves in the Silicon Valley, mostly with regard to consumer electronics, but it is certainly transferable into other areas like healthcare. Jeff Moore, and those of you who followed his work, he talks about this sort of notion of crossing the chasm, and this notion of what you as an innovator want to do is achieve a beachhead from which you can expand and penetrate the market. And then you have this notion of inside the tornado, or what happens when you begin to see mass market adoption of a particular technology. And I think that that's what we're going to observe over the next 2 to 3 years here. So can you pick the winners today? There are certainly some multi-billion-dollar capitalized companies, but I would predict that the market is large enough to support half a dozen. And so I think there's some great investment opportunities in the space. And more importantly, I think the space is going to deliver true value for both providers and consumers. Next slide, please. And again, this is a bit of an eye chart for which I apologize. But you can see that if you look at digital health funding, again, just trying to ground you in both the number of private equity or funded deals that are occurring on an annual basis and the amount of investment capital that is going into the space, you can see that last year, for example, there was almost $7.5 billion invested in over 374 companies. The average deal size is about $20 million. If you accumulated this investment hierarchy over the last decade, you'll see that we're upwards of 35 or 40 billion dollars of investment in digital funding, and that stuff will begin to result in very substantial products and services within the space. Next slide, Ned. So what's the value proposition? Why on earth would you want to do this? Why is it better to do it with telemedicine than to do it in person? And it's not a complete substitution of in person. There are going to be activities that I think simply cannot be done. remotely. But I would predict that that grouping of things that can't be done will shrink over time. And so I think that the key metrics of value proposition are, is it efficient? Is it effective? And does anybody like it? And so in terms of efficiency, you obviously eliminate completely the notion of travel time. And that's really lost opportunity cost. And for any of you who've experienced, I would say, the wantonly inefficient nature that characterizes most outpatient medical care, you not only incur inefficiency in terms of travel time, but you also, in many cases, and there are some notable exceptions, you incur substantial wait time, both at the point of care and then subsequently awaiting the results of diagnostic tests and things of that nature. Hopefully, this is a lower cost proposition. It's lower cost because you don't need the bricks and mortar associated with a outpatient facility that might have to comply with a variety of state dictated health planning requirements. Hopefully it's more convenient and it's more accessible. And so just at the highest level, so what is the aim here? The aim is to reduce friction in terms of just pure economic efficiency. That's the goal here, reduce system friction. And in terms of efficacy, in other words, does this actually work or does it work better? I think what you can look to is specialized expertise. So for example, it's a well-known phenomenon that there is a maldistribution, malgeographic distribution of both specialty expertise and accessibility to specialists. So if you're in a rural area, it is unlikely that you're going to find a world expert in a highly esoteric area of medicine. Whereas if you eliminate the physical barrier that's necessitated by in-person care, you have the ability to access on a worldwide basis specialized expertise that would simply be unobtainable. And that should result in quality improvement and reduced access time. And I think both reduced access time as well as quality enhancements are evidence of effectiveness that can be accomplished virtually. And then finally, and I probably would not have put this up on a slide 2 months ago, but there's a reduced risk of infectious disease transmission by utilizing virtual care. And then in terms of satisfaction, and I think the customer is both the provider as well as the patient, I believe you'll see enhanced customer satisfaction. And if you look at the metrics of how many consumers evaluate their healthcare experience, it's often not based on actual clinical outcome. And I think the reason for that is that clinical outcome is stunningly difficult to actually objectively assess. But what consumers can assess, and what they often do assess, is the comparable customer service they experience from other vendors of similar service products. And what unfortunately often occurs is that healthcare doesn't score very well. And it doesn't score very well because in many cases, the entire system is constructed for the benefit and convenience of the provider and not of the ultimate patient and consumer. And so it is my belief that with the advent and adoption of telemedicine and digital health, you'll get actually increased customer satisfaction because data that they have wanted in terms of something as basic as being able to access their clinical record doesn't require a release form fax to a medical records department followed by a 1-week delay and a bill for photocopy services, a virtually unintelligible and certainly not, you know, collated data. Whereas, you know, for many of us today, our medical records are online and they're accessible to us. And if we wish to see how our blood pressure or our lab results have trended over a decade-long period of time, we're now able to do that. And that, I think, will continue to empower the consumer, because they will have data that's, you know, quite literally, you know, at their fingertips. And then finally, as many of you are aware, you know, with the advent of genomic testing and clinical and quality clinical information that is available through, you know, a variety of websites, you can really get an extraordinary amount of consumer education that I think will make for better informed decisions. And that is already being enabled by the advent of the World Wide Web and hypertext transfer protocol and all of the underlying technologies that make for the world that we live in today. So I think therein lies the fundamental value proposition. You know, better, faster, cheaper, and happier. So next slide, please. Well, there is regulation, and it is in the form of the Food and Drug Administration, the Healthcare Privacy, you know, Act, the HITECH Act, which funded the adoption of electronic medical records, and finally, state provider licensure. And it's non-trivial, and people need to pay attention to what aspects of it require medical device licensure, what aspects of it need to be utilizing secure protocols, and how do you comply with a state licensure on a local level. Next slide, please. So what are the applications? You know, in my mind, you can have both diagnostic activity, you can have treatment activity, and you can have both. So functionally, you can do diagnosis and treatment. Again, I don't mean these therapeutic areas to be exhaustive in any way, but just some examples and some of the impact. As many of you know, it is now frequent that if you need a prescription drug, it is highly likely that your provider will use e-prescribing. And that has extraordinary benefits in terms of both quality control, because what we can do is we can make certain that the drug itself, the drug dosage, the treatment regime can be specified and quality assured, so that we don't accidentally have under or overdosing or inappropriate drug prescribing occurring, because we can check for drugs that shouldn't be prescribed together, or we can check for dosages that are not appropriate. And we can carry that further in terms of providing to a consumer the opportunity to maybe receive those medications via mail order, which might result in dramatically lower costs. So e-prescribing has been with us for a decade. It appears to have fairly substantial adoption. I mean, ironically, if you want a hard copy prescription today, for most of your providers, they will simply print out the electronic prescription that they have themselves composed. One of the areas that I think is, you know, and these are not, again, meant in any hierarchy of, you know, beneficialness, but I've been, for many of you who know, I've spent a lot of my career working in behavioral health. And so I'm hugely excited about the ability to do mental health therapy using a virtual modality, because I think that the physical presence nature of that is often stigmatizing, in addition to being inefficient. And telepsychiatry, telepsychology, I think really is a perfect application of virtual care. There are certainly great aspects of dermatology that can be adapted to a tele platform. And in a shortage, in a area in which, at least in the United States, there's an acute shortage of dermatologists, we can certainly expand the access to quality dermatology using telemedicine. The same is true of pathology and radiology and neurology and cardiology. So anytime that you have a digital image of for diabetic retinopathy, for example, or for EEG or EMG, or almost any of the, and radiology is really probably the wrong terminology. If I'd thought about this, I probably would have characterized it as medical imaging, because some of it, like ultrasound and MRI, does not use radioactive substances. But digital imaging is a broad area, and virtually the entire content today is digitized. One of the things that I think has been observed in the pandemic today is the use of tele-ICUs, where you can have specialized expertise using virtual connectivity connected to online digital physiologic monitors, so you can expand the treatment capability of these fairly dynamically expanded ICUs that we've been forced to set up to handle the influx of the severe COVID cases. And then finally, virtual clinical trials. This is another area that I'm particularly excited about, because I think that it is already expanding the participation in clinical trials. The recruitment of patients for clinical trials is probably the most inefficient aspect of conducting those trials. And so as it's possible to participate in those trials using remote sensors and using virtual visits, I think it's improved the accessibility of clinical trials to a large part of the population that for a host of reasons have been excluded. And then in terms of geography, in the world of the past, telemedicine was really focused on rural to urban, but now we're seeing widespread use, urban to urban, and specialist to specialist, and primary care to primary care. Next slide, please, Ned. So how do you get paid? Because ultimately, at the end of the day, and Ned will know this from my other talks, I always ask that, my mantra is no money, no mission. And it's necessary to actually get paid in order to make all this wonderful stuff possible. There are really, in the US at least, 4 primary payers: Medicare and Medicaid, commercial insurance, and private pay. And the really good news is that Medicare, and I will, this is not a paid political announcement, but I have been stunned, as have my colleagues, at the responsiveness of CMS during this time of crisis. They have provided advanced funding. They have provided multi-billion-dollar grants. They have relaxed regulations that required previously in-person visits. They have vastly, under their, at the moment, under emergency regulation, really enabled a lot of aspects of telemedicine that were significant barriers to its adoption previously. And I give them wholehearted credit for their initiatives in this most recent crisis. And I think that's also been reflected in Medicaid. Actually, ironically, where often the commercial insurers will be followers of whatever Medicare does. Medicaid in many states have actually, certainly many of the states that have more rural populations, have been somewhat ahead of the curve in terms of reimbursement progressivity versus the private world. But the commercial payers, Medicare and Medicaid, are absolutely reimbursing a much more expanded group of telemedical activities, and I predict that that will continue. And then finally, as many of you know, there's a substantial private pay market with people simply paying out of pocket. And while I think that will always remain a niche, I think it'll be a substantial niche and one that shouldn't be discounted. Next slide. So what are the issues? And this really is the final slide that I have, and I'm looking forward to your questions and comments, but obviously adoption rate. So if we'd had this, if this class had been scheduled in Ned's fall class, I would have said adoption rate is a serious issue, that we're less than 5%, that even though you've had a variety of positive things to enhance adoption, it's still been minimal, and it still is minimal. But I think the last 6 weeks are when the tide really turned. And I don't think there's any going back. I think consumers and providers have been remarkably favorably impressed with the facility by which this can be utilized, by the range of activities that can be conducted. And so I'm quite bullish that we are now going to enter the exponential adoption rate phase of this technology that we've been waiting for a long time. I think interoperability is really going to be one of the significant and ongoing barriers. So it's not unique to telemedicine. It is certainly a characteristic of the way, certainly in the United States, we have financed and adopted digital health. And so while there are agreed upon standards for various things like diagnosis and procedure, and we're supposed to have, crosswalks between different vendors, proprietary implementations of various standards, the reality today is that the systems are not interoperable. And if you think about, for those of you who, you're probably not my age, but will remember the days before we had something wonderful called hypertext. We used to have to use something called FTP, which was the way file transfer protocol, which is the way that we had to access databases from a remote location. You sort of had to know the specific protocol of the UC Berkeley computer or the MIT database in order to get anything out of it. Whereas obviously once hypertext was, published and adopted, it became possible. You didn't need to know the file transfer protocol of a specific location. You could use hypertext and it would make the translation for you, and that made the information much more available. But interoperability, I think, is a serious obstacle across the entire digital health environment in the United States. And then finally, I think that we're in a period where the business model is evolving. In the world of the past, I think I would have characterized business models as either been business to business or business to consumer. And you can, figure out whether they're technology as service or whether this is a technology enabled service activity. But I think the business models will evolve, and they'll evolve in response to ultimately what makes sense for providers and consumers. I think that providers are justifiably concerned that if they were to simply open themselves up to, their patient population wanting, sort of real-time response to every email inquiry, that they could spend their entire lives responding to emails. Many of you, some of you who may be providers, and those of you who aren't, who know providers, will know that the burdens of entering data in an electronic medical record are non-trivial. And I think many providers are legitimately chafing from the increased workload that has burdened them with for a technology that ironically is actually has a better value proposition to the consumer than it often does to the provider. And so I think that that will impact the business model discussion. Obviously, reimbursement will evolve, and that will have an impact. So again, without wanting to have been totally exhaustive, hopefully that'll give us a framework to have a dialogue about what you all see and what the potential is and where we go in this new age. So thanks very much for your patience and allowing me to frame a discussion, and I look forward to your questions.
Gene, thank you so much. And let me just pick up on one, because the first question in, which was at the beginning, was this moment sort of post-COVID, and people were interested in your thoughts about, will CMS actually revert back, or will there just be too much pressure to, as you were sort of suggesting, maintain the level of coverage that we're seeing today because of COVID?
Well, the first thing is, I think, so it's a great question. I actually think that we've crossed the Rubicon, and that there's no going back. And there's no going back for three reasons. The first is, and I don't want to throw cold water on anybody's parade, but I think that COVID is going to be with us and is going to affect our society for years. And as a result, we're going to need to adapt the way we render healthcare and the way we receive healthcare for a long time, for years, not days or weeks or months. And second, it's a bit like, when you have an innovation that is so profound and so well accepted by all participants, you can't take it away. And so I do not think, I think that they will, I've got nothing but compliments for the folks at CMS and their response to this pandemic. I would also say, incidentally, and I'm on 2 hospital boards, and I'm invested in dozens of healthcare service companies, and we should all offer our sincere appreciation to the providers that are struggling really through this extraordinary period. My own son is an emergency physician in Chicago. The pressure that these providers are under to render care during this time is really unprecedented. And the really good news is that we are blessed with some great providers. And so I think we're gonna, there's no going back, Ned. I think that the government will recognize the value that these relaxed regulations have. I think, frankly, we've got acute provider shortages, both maldistribution and just real shortage. And so I think you'll see, for example, we've had scope of practice relaxation in a number of states. And I think you're going to see that because as our population ages, there's simply not enough providers, and we can't train enough providers in the short term, to deal with the demographic bulge that most of the developed world is experiencing.
Yeah. Thanks, Gene. Another one is coming in regards to apps. So there's sort of, are you in favor of point solutions? In other words, an app for a particular disease, or a more platform solution that can address wider breadths of conditions? And where do you see that trend?
So I think there's room for both. As an investor, I'm always nervous about what we would call point solutions. Now, if a point solution addresses as broad a therapeutic category, for example, as congestive heart failure or COPD, well, that's a point solution that has a, multi-$100 million addressable market. And so I get pretty excited. But if you talk about at the opposite end of the scale, a point solution that address a very rare genetic disease, where there are less than 1,000 patients in the United States, I would say that's probably not an investable proposition simply because the limited nature of the addressable market. I think that there's always in technology, as many of you experience in your daily lives, there's always a sort of balance between best of breed and comprehensive solution. I think the key in terms of whether you want a broad platform or a point app is their interoperability. And therein, in my mind, lies the key distinction. If we are going to have best of breed, and I think we will, because specialists and consumers will want a solution that is highly tailored and specific to what they need. It'll need interoperability and the ability to exchange data with a larger platform. Mm-hmm. Hopefully that's helpful.
Yeah, thanks, Gene. Someone's asking a little bit more about the payer question and wondering if payers and really the cost, are they expecting, will the payers eventually feel that there's a lower cost associated with this? And yet the providers are really arguing for price parity. And so I'm just curious where you think this will, funnel through. Yeah.
Well, I think it's a great tension. Yeah. I think the worry that the insurers have had is whether or not this is simply going to be an uncontrolled demand equation that they're going to be on the financing end of. And that because the barrier, is so low, that there'll simply be excess utilization. So that's the, perspective, I think, of the actuaries and the people, is that the insurers, the payers, that we simply don't have any idea if we unleash this very facile technology, what kind of consumer demand that it will, inspire. And incidentally, there's some, fairly good data that suggests that if you put up some procedural barriers to access, that it will have the effect of sort of self-triage. It's like when you call up one of your service vendors and are told you're going to have to wait 5 minutes on the telephone for an agent. Well, I go to the website when I'm told I'm going to have to wait more than 5 minutes, and if they tell me the wait time is 30 minutes, I hang the phone up. And so I think that I think there is some justification that demand is hard to predict at this point in time. And hence, many of the payers have wanted to roll this out in an incremental fashion so that they could get an idea what that demand equation was indeed going to look like. On the other side, you've got the providers. And in most cases, if you think about a provider, their stock and trade is their time, and it's measured in minutes. And they, for the evaluation and management procedure codes, it's based on the duration of the patient experience and what they actually did, the intensivity of the activity. Whereas many of the proceduralists, it's based on a procedure. It's based on, did I do a particular surgery or a diagnostic test? And so my view is that let's deal with the easy ones first. I think remote diagnostics, whether they're done non-remotely or remotely, it's hard to argue, assuming that the quality is the same, that you shouldn't get paid the same amount of money. I do believe, and I will just share this with everybody, that there is an issue with continuous monitoring. And the issue with continuous monitoring is separating the noise, from the real data. And that is that it's certainly technologically feasible to measure a whole lot of stuff today on a continuous basis. And I think that the real issue is, I think we have to be judicious in our ability to apply intelligence to and data analytics, so that we're simply not overwhelming providers with data without information. What we need to do is we need to reduce the signal to noise ratio so that we've got actionable data that will make a difference in what we do, as opposed to doing it because we are able to do it. So that would be one thought. That's diagnostics. In terms of therapies, I think that as long as there is the same substantive activity is occurring, it is hard to argue, at least for the professional component of the time spent, that they should not be compensated comparably. But as many of you know, as the studies that have built what's called the relative value systems, which are the basis upon which the government and private payers establish a payment mechanism for a particular provider activity, there is a component that is time-based, but there is also a component that is sort of underlying resource-based. And so if a provider has to operate an office that they rent or lease, and if they have to buy beds and chairs and all manner of stuff, obviously, if things are done remotely, the component of that, metric that's built within those rates needs to be adjusted, where you don't have those overhead costs. And so I think it will be an evolutionary process. I don't think it is appropriate to simply pay them on a parity basis over the long term. I think in a transition phase, and I think we will be in that phase for the next several years, it probably is appropriate. Because ultimately, if you think that it is more cost efficient, then what you want, and I think further, we will need to do quality studies to confirm that we are not seeing a diminution of quality. If we believe that it's ultimately as effective or more effective, and it is more efficient, we would want to financially incent the adoption. And so I would argue that that's a beneficial societal goal that will get us to a more cost-efficient end result.
Great, thanks, Gene. If your time is available, I'm wondering if you could spend another 10 to 15 minutes with us, because we have quite a few questions that have been flying in here, if your time so permits.
You bet.
Great. One other one that's sort of connected to what you were just saying is whether the increasing use of telehealth will actually make us more comfortable with AI-generated health recommendations in the future.
Well, I don't know the answer to that. I think that I'm a huge believer in the promise of AI, and I'm watching very carefully how it progresses. So the things that I'm particularly excited about today are where it's applied to image analysis, particularly with regard to diagnostics, because it's very clear that some of these image analysis methodologies using neural and processing, probably will ultimately be superior, but I would say that the jury is still out. And that's one where I think the technology is particularly well adapted. Whereas other areas which that aren't related to spatial analysis, which I think is a data problem, I think are going to be slower to achieve both provider credibility as well as consumer acceptance. Without again, the consumers, represent a wide variety of scientific knowledge and acceptance. And so I don't know that telemedicine will be viewed, will give people greater confidence in AI or not.
Mm-hmm. There's a question coming in, and it's certainly very timely given what we've seen in the trends with both nursing home and assisted living. but I'm wondering if you could share some of your thoughts of where telemedicine will be in senior living environments, and specifically maybe in assisted living, memory care, skilled nursing, and as you alluded to earlier, in behavioral health.
So first, the good news is it's already being used. As many of you know, there's a large population. I think there's something like 20,000 skilled nursing facilities in the United States. I don't know what the assisted living number is, but it's large. And if you broaden that definition to sort of congregate housing, there's a huge number of people living, you know, elderly people, frail people living, you know, in congregate residential environments. And that's a population that has high health needs, often chronic diseases, and telemedicine is already being utilized to, you know, to provide access to that population, because in many cases, just simply physically moving them from point A to point B is a non-trivial activity. They don't move quickly. They don't move without friction. And that, you know, if you just your classic case of a dementia patient who, you know, any disruption in their daily routine might be, you know, a precipitating cause for, you know, clinical, you know, decline. So I think telemedicine is an ideal solution to the accessibility challenges of that population. So I'm hugely bullish on it for that population.
And what about some of the publicly traded companies in this space of telemedicine, be it Teladoc or Livongo? They're wondering if these early adopters that have been out there in the space have really sort of, if they're going to dominate the place for years to come.
Well, certainly those are great companies, and they're early on in the adoption equation, and they've established important relationships with healthcare delivery systems and with payers, and that gives them a profound advantage. But I don't think that, I think this is we're still in the Oklahoma land rush phase of adoption. The people that got off the starting line early, you know, have an advantage, but I don't think that advantage is insurmountable. I'm not advising either pro or con, you know, any equities. I want to be really clear about
that. And someone is asking this question, which I hadn't really been thinking about, but the exportation of telemedicine from the US to other markets like Europe and Asia, for example, do you foresee that in the short or long term?
Well, ironically, that's been going on, but ironically, it's actually been more the opposite way. So there are certainly, you know, U.S. academic medical centers that have affiliates internationally who've utilized telemedicine technologies to deliver specialized expertise to those less developed places with a shortage or inadequacy of specialist providers. So that's been going on. But ironically, actually, there's been a fair number of US trained and licensed providers, cardiologists and radiologists, for example, who've been doing activity for US patients, actually from lower cost settings. Those of you familiar with this notion of Nighthawk, the radiologists that do often secondary readings, but often even now primary readings, that's been going on, you know, for 15 or 20 years. You know, EKGs, secondary overreads of cardio tracings, has been going on for a dozen years. Pathology slides that are digitized have been moved around the world. So there is certainly an opportunity for US trained providers to provide that specialized expertise, but there is also an opportunity to see lower cost providers render care to US patients using the similar technology.
Yeah, and what about, what B2B telemedicine opportunities are you most excited about? And the questioner is asking in particular things like data management, some of the cybersecurity issues, diagnostic technology that you referenced earlier?
So the ones that I like the best at the moment fall into two categories. And this is now personal bias. I love the impact of clinical trials. So virtual clinical trials, in my mind, are ideally suited for this technology to solve some long-standing problems such as patient recruitment and engagement. So if you think about how clinical trials often historically have recruited patients, it's stunningly inefficient. If you drive around in your automobile, or that's not done a lot in the more recent past, but you'll notice that many radio stations advertise for clinical trials that are looking to achieve referrals, self-referrals. And if you ride the mass transit, you'll see quite literally advertisements and billboards for participation in clinical trials. That's a stunningly inefficient, not very well directed, and I think wasteful recruitment activity that I believe that this kind of technology will replace. And so I'm very excited about the business-to-business model of aiding pharma through outsourced virtual clinical trial recruitment. So that would be an example. I actually think that probably and there will certainly be, I would say, some opportunities to deal with data management. But those opportunities I don't think are unique to telemedicine. They're more broadly applicable to digital health. And so I don't think that telemedicine is the deciding parameter there. I think, and I would argue that, many of the technologies they're utilized, in other words, we're doing geopositioning, which is how, Waze and the various technologies like that tell us how long it's going to take to drive from point A to point B and what the alternative route that we could take and the time and all that. Well, that's going to be utilized on a highly specific basis. So imagine that you have a patient that has Parkinson's and you want to see if you can determine if there's anything about their activity level which would let you know that they were either improving or declining. The positioning, and you can measure their gait, for example, very precisely using connected devices. And I think that's another great example where you improve the clinical quality, you reduce the friction of how you collect and validate the data. And so I see those as that connected device opportunity as, the sky is the limit. There will be many areas where we can do things that we might not have done in the past just simply because they weren't feasible, that are now with this digital health infrastructure, profoundly enabled.
Great. Gene, we're going to have time for just probably a couple more questions. One here is what do you think will be the impact of telehealth, or the telehealth impact on malpractice insurance?
No, that's an excellent question. I'm really glad that got asked. Often, malpractice is sort of the boogeyman from the provider's perspective. This notion of defensive medicine and, doing a bunch of unnecessary things because you want to, avoid, a malpractice claim. I think it's incumbent upon telehealth to validate the quality of its activities. And so, and the good news is, for example, like in the same fashion that this webinar is being recorded, it is certainly possible to record telehealth, activities and then have them subsequently peer reviewed so that you can do quality assurance. And I think that you can, over time, there will be, randomized clinical trials that look at randomly assigning patients to virtual visits versus inpatient visits and then evaluating the outcome. And I think that will be needed to be done to validate that you're not degrading quality through this vehicle. And ultimately, I think that the insurance actuaries are going to be compelled by, factual data. But the plaintiff bar, as it always does, will look to exploit, any malfeasance. And so my cautionary note to anybody who's engaged in any aspect of medical care is to make sure that you've got very robust compliance and quality assurance activities built into all of your processes and activities.
Yeah, and someone is just sort of a follow-up to your point about the Rock Health slide and the investments in digital health in general, and where the trajectory is going to be going over the next 10 years, particularly given what we've learned in the pandemic, and whether that will really push the envelope of VC funding in this space, which is it's been a relatively small compared to, for example, the biopharma space in general and the device space.
Well, so, I mean, let's just, again, why is digital health smaller than pharma? Well, depending on whose data you read and depending on whose, the evolving state of the art, if you want to get a drug from a scientific idea to the pharmacy, costs $1 billion to $2 billion and takes 10 years and has a 1 in 10,000 chance of success. So the odds there and the magnitude of expenditure there is very, very high. Whereas I think digital health and telemedicine are able to leverage scalable technology investments that have been made that are utilized by other industries than healthcare, so that healthcare, as we all know, is largely labor. Something like 60% of the healthcare dollar is spent on labor. And so any kind of utilization of technology to reduce labor should accrue very substantial economic rewards and benefits. I think that, and so the good news is that we can leverage on technologies like broadband and mobile and cloud and, AI and natural language processing and all of these technologies that are so robust that we experience in our consumer lives in every aspect of what we do today. I mean, just imagine how you would have survived this shelter in place if you didn't have the ability to order goods and services online, if you didn't have the ability to access, information, and for those of us who can work remotely, maintain commerce during this period of social distancing. Any rate, I, as many of you who know me, I'm an optimist. I'm a believer that these technologies will, are beneficial, and that, but we'll need, like everything, to shake them out and figure out which ones are more beneficial than others. And there will be a reckoning, because not everything that we can do should be done, and not everything that we will do will be beneficial. And it'll take a while to figure those things out, but ultimately they get figured out.
Yeah.
So I hope this has been useful and helpful to the Terrier world. It's one of my, greatest satisfactions has been to maintain an interaction with the BU family. And Ned in particular has done such an extraordinary job with the healthcare program. And it's something that, the messages that I would leave all of you with today are, this is now the 5th and probably the most severe of the economic dislocations that I've experienced in my professional life, dating all the way back to the year I graduated from college. 1973, for those of you who read economic history will know, was a recession. And so, I've been through them in 87, 88. and 99 in 2000, and 2008 and 2009, and now unfortunately 2020. But we'll get through this. It'll be not without pain, and this may be the most pain that we've experienced in a century economically, but we'll get through and we will prevail because we're terriers and we're tenacious, and don't lose heart. I'm privy to some very exciting activity that's occurring in therapeutic approaches to COVID. And so I remain very optimistic that while it'll be difficult in the short term, we're seeing just an extraordinary, really extraordinary ability of the scientific community to come together with purpose to develop positive solutions. And so barriers are being broken down daily and progress is being made. And we should all feel very good about that. But at the same time, say your prayers tonight and thank all the providers that are putting their lives on their line for our benefit, and all the first responders and everybody that we are so very blessed to have. Thank you all, and have a wonderful day wherever you are.
Thank you, Eugene, for being here today and for being part of the Boston University family and a member of the Questrom family. We very much appreciate your insights and joining us today, and also appreciate your extra time to answer some of the additional questions that came flooding in. So stay safe in Florida, and thank you all for joining us here today for this special webinar with Gene Hill. Thank you all, and have a good afternoon.